Dear colleagues, it's a great honor to be here sharing my clinic experience with you all at this platform. I have been a premium XP user since 2014 and now see myself among such an amazing group of clinics from all over the world. It's truly amazing. So I'd like to thanks to Dr. Maurice Salama for his kind invitation and say that I'm truly happy to be part of XP family. I come from Oporto, and what you see before it's a video from my clinical practice, which is Iron. We also have an educational center where we have hands-on courses, short clinical residence, cadaver labs, and so on. During 2008, I had the chance to meet Dr. Miguel Stanley in a dental meeting in Portugal, who challenged me to join him and his team at White Clinic. I accepted the challenge and it's been a pretty cool journey working together. So thank you, Miguel, also for trusting me and for pushing my limits every single day. My practice is nowadays focused on reconstructive surgery and aesthetic implant case management, what includes a perio, implant, and restorative approach. So next March, I will be among all these legends of dentistry to lecture at Dental XP Global Conference, and I would like to invite you all to be present. If you are not registered yet, go to the website and apply now. Premium members had free registration, and I would like to see you all there. So my topic for today is focused on biological approach on the aesthetic zone. From immediate to reconstruction, my goal it's been to use more and more autogenous tissues combined with a minimal invasive microsurgical approach in order to have the best pattern healing and aiming for scarless surgery, what should always be a goal when we are talking about the aesthetic region. The magnitude of the defect and the periodontal biotype of the patient will define the technique to utilize, but normally my protocol in reconstructive cases is 1 time bone and 2 times tissue. For healed ridges, we try to avoid opening a full thickness flap more than 1 time, taking advantage of implant placement time and tunneling procedures to do the soft tissue augmentations in order to have less resorptions and less scars at the end of our treatment. So when we have sockets type 1 to manage, our preference goes for the socket shield technique. If the case is well selected, it's a fast, safe and efficient technique to have an amazing aesthetic outcome. This clinical image that I'm showing here is from my first case of socket shield technique. According to the literature, the socket shield technique is one of the techniques that give us more stability in the buccal palatal dimensions and to maintain the keratinized gingiva width. So if we look at this clinical picture, that is from my first case of socket shield technique, we can see the band of keratinized gingiva completely maintained. In this case, the implant was placed almost 4 years ago and still with the share side provisional. And when we take out the share side provisional, what we see is a perfect emergence profile with zero collapse and the maintenance of the keratinized gingiva was totally obtained. But the clinicians may be uncertain what tissue grows between the socket shield and the dental implant in humans. Is it periodontal ligament? Is it new cemento? Or is it partial or full periodontal regeneration? If we see in this volume, when I'm playing with the layers, we can see the scalpel of the root that is in front of the implant. And when we take the layers out, we can see tissue with bone density between the root and the implant, which suggests us that bone has grown inside. Let's go for a more close-up view. So in sockets type 1, our preference is to apply socket shield technique. It is mandatory to have a CBCT in order to precisely evaluate the conditions of the socket, and obvious also to plan with accuracy the better 3D implant position according to bone availability, root position and prosthetic plan. In this case, we analyze the position of the root according to the alveolar ridge. In this case, we have a class 3 from the classification that Howie Gluckman came out last year. Another issue for us in the immediate implants is to have a flapless approach. We all know that it's more easy to maintain than to recreate the gingival architecture that we have in the mouth. So the success of our treatments does not only depend on the technique that we choose for each case, but it depends also on which way we apply the techniques. So our traumatic procedure since the very beginning with the extraction time is needed to achieve the outcomes that we all desire. Small instruments, magnification and illumination allows us to provoke less trauma to our patients and to have better aesthetic results. Buccal plate and the bundle bone have three sources of nutrition: the periodontal ligament, the bone marrow in thick biotypes, and the periosteum. Imagine in a thin periodontal type a flap surgery for place immediate implants in the aesthetic zone. It could be a catastrophe. Even preserving the periodontal ligament, if we open a flap, we know from the literature that we will have some buccal collapse, and if we raise the papilla, we will lose something in height too. So let's take advantage to be working on sockets type 1. Let's be delicate with our procedures, provoke less trauma, so expecting better surgical and restorative healing of our procedures. We know from the literature that when we open a flap, at least we have 1 millimeter of collapse. So when we compare flap surgery with flapless surgery, we know that with flapless surgery, immediate implant placement, we can have less bone resorption. Root preparation in this technique is another important issue. As we have different spaces to manage due to the presence of the root, the implant diameter selection is also a key factor, so it has to be done carefully. In the earliest, we were educated to choose our implant's diameter in respect to mesiodistal space, but nowadays for immediate implants we use bucopalatal reference as well. So for the root preparation we can use several kits. We have the Brassler kit developed by Maurice Lama, we have the kit developed by Megagen, but at least we have to have lots of precision and take out the root ideally always like this. As we have different spaces to manage due to the presence of the root, the implant diameter selection is a key factor too, so it has to be done carefully. In the earliest, we were educated to choose our implant diameter in respect to mesiodistal space, but nowadays, for immediate implants, we use bucopalatal reference to do it. So I always guide myself with this article, and this article tells us to choose the implant according to the buccal palatal dimension of the alveolus in order to have at least 3 millimeters of gap between the outer surface of the implant and the inner surface of the buccal bone. This 3 millimeters allows us, if we select the implant like this and we trim our root more or less with 1 millimeter and a half of thickness, we still have 1 millimeter and a half of security in order to not to touch with the threads of the implant with the root. I know that sometimes it could happen and we not experience problems, but for me it's a risk factor for this technique if we have the implant in touch with the root, because we can provoke micro movements on the root, we can provoke micro fractures on the root, and that kind of micro fractures cannot be replaced by coagulum because they are too small. So we got to be aware, because that kind of micro fractures could be a source of infection. Another important question is, does the gap size matters? My answer is yes, it matters, not only to avoid the undesired pressure on the shield that I was talking before, but also to make easy if we want to fulfill the spaces with some graft material or bone substitute. And another issue is to give us more space to have the ideal design of our prosthetic restoration or our customized healing abutment to make the socket seal. In this technique, provisionalization for me, it's always easier when I have the tooth or the veneer of the natural tooth of the patient. In this case, I utilize a PMMA abutment which have machine surfaced, and this machine surface will stay underneath the gingival margins. So I have the best of the two worlds. I have a machine surface in contact with my tissues, and I have the veneer of the patient to glue it in on the abutment. This is the final CBCT, and this is a small video just to show you how the patient should come out without any contact in the static and dynamic occlusion. So the impressions in this kind of cases, aesthetic cases, nowadays not only in the aesthetic cases, we should always customize it for the profile of our implants. We know from this study, from the dual zone therapeutic concept, that when we graft the gap and when we customize the emergence profile to support the architecture of previous existing thing in the gingiva, we will have better outcome results. So we should always go for customized profiles. The patient comes after 4 months without doing nothing. We just place the implants, the two provisionals, and look at the quality of the tissue, the volume of the tissue. Look at the papillas. It is amazing how this technique could maintain the tissues in place. In this case, we made two types of impressions, one analogic impression and one digital impression. The analogic impression was taken with the provisionals, and after we take the impressions, we can see that we have some bleeding. If we have bleeding, it means that probably we have adherence to our provisionals, and that's why we don't have any collapse. After it, we take the digital impressions and send the color to the lab and both impressions. And quickly we have the answer from our lab technician that he wants to utilize the analogic model because he superimposed the photos of the clinical situation and the model, and they are really the same. Our preference in this case is the prosthetic restorations is to have a frame in zirconium that will be ceramized. Here you can see two beautiful crowns in zirconium from the dental technician Mr. Oleg Blaskiv, which is a great technician. We can see several aspects of the crown with gingiva, without gingiva, and the model, and you can see the high translucity of these zirconium frames with the ceramic. This is the final restoration in place. And we can see that the volume, the papillas, the color, everything is on the correct shape. So let's focus now on sockets type 2. On sockets type 2, our preference is to go for an immediate dental alveolar reconstruction or IDR technique. What is the IDR technique? IDR technique is a surgical and restorative procedure and construct the provisional crown with proper emergence profile in the single procedure. This technique utilizes the tuber bone as the bone graft to reconstruct or to fill the gap. The tuber graft is very easy to collect and not painful for the patient, and give us a really cool amount of bone to reconstruct one alveolus or to other clinical applications. Not only to immediate implants, we can utilize the tuber graft, but we can utilize it to make alveolar preservation with the immediate implants. For example, in this picture that you see, I have performed a dual zone treatment concept, but I utilize the tuber graft instead of allograft. Or you can also screw a block of tuber, and after 4 months you can see In this little video of one reopen, you can see a complete integration of the block. When you utilize this bone in small particles, we should pay attention to the size of the particles in order to not to reduce too much the particles. We know from the literature that autologous bone was not considered the best choice to make alveolar preservation, but let's go deeper, for example, in this study from Mauricio Araújo and Jan Lind. This study compares two groups. In group 1, in the first quadrant, bone chips harvested from the buccal surface of the mandible were utilized to make the alveolar preservation, and in group 2, the material utilized was by os collagen, which is 90% of the proteinate bovine bone and 10% of collagen fibers. What happened? They measured the collapse in the coronal, middle, and apical area of the alveolus, and the results show us that BioOS was totally superior to do this kind of preservation. Why? Because if we put only small particles of cortical bone inside of alveolus, it will resorb very fast. So the size of the particle is really important when we are mixing autogenous bone with another bone substitutes or when we are utilizing autologous bone alone. So the size of the particle, it is very important. Let's see the effect of the graft bone particle size on bone augmentation in a rabbit cranial vertical augmentation model. They divide the rabbits in three groups. One utilized small particles, Group B utilized large particles, Group C utilized a mix of small and large particles of autologous bone. They measure the resorption at 4 weeks and at 8 weeks. And as you can see in the graphics, the large bone particles are the ones that have less resorption. So we should always be aware of the size of the particles that we are collecting to utilize as a bone graft. The rest of the approach, it's normal for an immediate implant. We always aiming to put our implant on the palatal wall, creating 3 millimeters of gap in order to fill it and restore properly the defect on the buccal wall. After we place the implant, we fabricate the provisional restoration. Final step is to harvest the tuber graft to reconstruct or graft the alveolus. As you can see, this is the provisional restoration at 4 months in this case, and when we unscrew the provisional restoration, we have this kind of image. Then we can transfer our emergence profile and go for the final restoration, which is always our preference, is a zirconium frame molded in the tie base and ceramized. Here you can see the 2 dimensions X-ray tomography with the provisional crown, and you can see 2 years follow-up CBCT when we see the complete integration of the bone graft. The next topic that you will see now is protocols for healed ridges. And sometimes we go for early placement. We know that early placement with contour augmentation is one of the most documented techniques in the literature. And sometimes we go just for tissue augmentation. Let's see this case of early placement where we have used anterior nasal spine as a donor site. Firstly, I would like to notice you that we make some incision design modifications. We just perform one vertical releasing incision instead of 2, because one vertical releasing incision gives us the amount of flexibility of the tissue that we need to close the flap without tension. We know from the literature that one vertical releasing incision could allow us to advance the flap 113%. 2 vertical releasing incisions could allow us to advance the flap 124%. But the periosteal releasing incision is the most important one and could allow us to advance our flap 171%. So when we perform the vertical releasing incision, we should not go through the mucogingival line too much. We can go like 1 millimeter and then tunneling from the inner side of the flap. And this will allow us to have better healing and better feedback from the patients, because we know that the vertical releasing incisions are the ones that give more discomfort to the patients. Here in this slide, we see the internal incision or the periosteal releasing incision, which is the most important one that could give us the most advance of our flap. As you can see, we should do this kind of incision this way, seeing the blade through the transparency of the tissue and not opening the flap and try to split, because in lots of situations we can end with the perforations of the flap. With this kind of releasing incisions, we can achieve this suture without any tension and have a great healing of our patients. Here you see that in this case we use the anterior nasal spine as a donor site, because we can collect the autogenous bone in the same axis that we have made to place our implant and to make the contour augmentation. So we are using autogenous bone, but we are just making one flap in the mouth of our patient. So we place the implant, and once the implant has some threads exposed, I prefer to go for the layer technique and to put one layer of autologous bone in contact with the implant, protect this layer with xenograft, and then overall place a pericardial membrane that should be fixed in order to give stability to our graft. Once we have split our tissues in the proper way and have sutured our patient without any tension in the flap, we can expect a healing pattern like this, with completely closure of the tissues in the crestal incision. And then we bond a provisional, always undercut, because we know that the tissue will migrate coronally. This is the 3 months post-operatory CBCT, when we can see a completely integration of our contour augmentation, and we have the sufficient amount of bone that will give stability to the tissue over the years. But when we are looking from the occlusal view, we still have an horizontal deficiency. And this kind of horizontal deficiency is treated with tissue augmentation, not with bone augmentation. So in this case, once we have raised the flap one time and we don't have any kind of fixation material to take out, we are going to utilize a tunneling technique, the palatal island flap, as we will see in the video in the next minutes. But before this, we make a punch incision, we make an index of our implant, we send the index to the lab, and we ask to utilize our diagnostic model to put the index and the implant analog and to fabricate a provisional crown. Let's see now how we do the index. We do a small incision, we place the transfer of our implant, and we do this index with pattern resin. This index is to know where the implant is positioned in this diagnosis model. Then we customize our abutment with opaque resin to achieve a good aesthetic outcome, and the lab will construct our provisional, will trim the emergence profile of the provisional according to the article of Gonzalez. We know that in the subcritical area we should not have any pressure of the tissues. We make the polish of the provisional, and when the provisional is ready, we can go for our surgery. The palatal island flap that we are going to see now in the next video was described by TNT, and this is a kind of modification of the palatal island flap. This flap allows us not only to augment the soft tissue volume or thickness in the buccal site, but also to increase the papilla height. As you will see in this case and in the next case that I will show you, that we have a little improvement of the papilla, of the papillas. So first we do a punch incision with a circular bisturi, as you can see in the image, And then we go for a sulcular incision using straight microblades. You'll see in this video that I use like 3 types or 4 types of blades in only one surgery. If we want to achieve the maximum outcome, we have to have the right material to do our surgeries. I'm still doing the sulcular incision right now, and now with the 15 blade I will do 2 vertical full thickness incisions, one in the inner part of the adjacent tooth and the other in the other side, and then with this angulate microblade I will connect the 2 vertical incisions with one incision that is not a full thickness incision, is a split thickness incision, because then we start to tunnelize everything in split thickness through the punch through the sulcus, from the punch through the sulcus, and as you can see, I can see my blade through the transparency of the tissues, and I'm creating the pocket or the envelope to graft, to put my tissue graft. Once I have my envelope or my pocket created for the graft, I will harvest in Zucchelli style a piece of free gingival graft that I will depithelize outside of the mouth. After we have the graft preparation and the completely depithelialization of the graft, we are going to place the graft from the punch to the pocket. As you can see in this video, we have some sutures to help us to put the graft in the right place. And we do this suture and another suture for the other side. And after the graft is in place, we have a volume augmentation like this. 8 days healing. And if you remember, we came from this situation before the tissue graft, after the implant placement and bone contour augmentation, and we have this kind of situation after our tissue graft. And this is 8 days healing. You see that the healing pattern is almost the same when we are careful with handling our tissues and utilizing a lot of irrigation during our surgery. This will allow us to have these pattern healings. And then 1 week after, we screw the provisional and we wait for the tissue to go inside and fulfill the space of the papillas. And this was the initial situation before the implant placement and the bone contour augmentation. And this is how we send our patient to restorative dentists, with the ideal emergence profile, with with the space of the papillas fulfilled with tissue, and with a great buccal volume augmentation. So the next case, we don't perform contour augmentation at the time of the implant placement. We just perform 2-time tissue augmentation. Tissue augmentation at the time of the implant placement and tissue augmentation at the time of the reopen, using the same flap that I showed you in the last case. This is a high demanding case, high lip smile line. As you can see, the patient is wearing a flip-flop. So at the beginning, we ask to our lab to custom make us the surgical guide and the provisional, and we should always be careful with the material that we receive from the lab, because in this case, as you can see, the margins were too high, and if I guide my implant placement through this guide, I could hand with my implant too deep, and that will be an issue to the restorative dentist. So always take care and always pay attention in what you got from the lab. So I cut my guide, I cut my provisional, and this was our initial situation. As you can see, no papilla in the mesial part of the 11 and no papilla on the mesial part of the 22. So this is our initial situation. This case is a case of delayed approach, but as we have enough bone To expand and to put one narrow implant, we avoid the contour augmentation or bone graft in this case, and we are just performing tissue augmentation. Now in this video you'll see the incision, and this video the incision was recorded in real time. This to show you all how long sometimes I take to make a crestal incision in a edentulous space of one tooth. Take your time, be gentle doing your surgery. The tissues will have a better response. This kind of incisions allows us to split the tissues in the proper way, that we have the same amount of connective tissue and epithelium in the buccal part of the flap. We have the same amount on the palatal part of the flap, as we can see in the image. Then the next step was to split the flap in a closed way, like I told you before. As you can see, we control the blade through the transparency of the tissue in order to not have perforations. And you see that is a clean surgery without too much bleeding, and in this way we are going to make the periosteal releasing incision in order to have space to put a big connective tissue graft inside. After it, we are going to drill the implant and to expand the bone with the help of denser burrs in counterclockwise. You see that the reach is a little bit narrow, but with this burr, as you can see during the osteotomy with cropios irrigation, we are not taking the bone out. We are just moving the bone, condensing the bone, and expanding the crest. We place a 3.3 implant from Straumann, and then we harvest a big piece of connective tissue and we graft not only on the buccal, but we graft through the palate to the buccal in order to have some vertical tissue augmentation in the edentulous area and to start to have a little bit of papillas. This is how we suture, how we fix the soft tissue graft. And this is the end of our surgery, closing the flap without any tension and expecting a good healing. Another detail that I want to discuss with you is this kind of suture. When we are suturing the connective tissue graft in the inner part of the flap, this suture should not have too much tension in order to don't make any necrosis to our graft and don't provoke any scars in our flap in the aesthetic zone. And once again, we bond one provisional and we undercut the provisional, expecting this coronal migration of the tissue. After the first surgery, we have improved the soft tissue profile, and now at the second stage, we are going to do the same flap as I showed you before in the last case. Even after that big connective tissue graft that we use in the crest and in the buccal side, we still have some collapse after the healing and after the phase of osseointegration of our implant. One thing that I like to do in these cases is to keep my guide and utilize my guide to do the punch incision. After I've done the punch incision, I go for the sulcular incision and I start to tunneling like we saw on the movie before. And this flap allows us not only to move the tissue buccally, but as I told you before, to gain something in the height of the papillas. So after we have made the tunneling, we harvest a subepithelial connective tissue graft. In this case, we suture the graft in place, we put our healing screw with 4 millimeters of high, and we bond the provisional, always undercutted. And you see that the suture around the connective tissue graft is without tension. This is the final peak of the surgery, and this is 8 days post-operatory of the surgery. And when we see this image, we can be happy, having in mind that our problem is more or less solved. After this, we make our index. We go for the first model that we have from the patient, and it's always the same protocol. With the index, we customize the abutment, we put the index in the place, we design our emergence profile in the gypsy, and after this we go to the mouse we screw the provisional. This is our provisional. It's not a pretty provisional, but I used to say that the beauty of the provisionals is underneath. The beautiful of the provisional is to shape an emergence profile like this one, and then we go for the final monolithic crown. And here is the final picture before we screw down the crown. And as you can see, we start the case without any tissue in the papillas, and now we have two papillas. And here you can see before and after two surgeries of connective tissue graft, the crown in place, and the volume that we obtained. The next case that we're going to see is a vertical reconstruction in the aesthetic zone utilizing the Corey technique protocol. Corey technique protocol utilizes bone blades to reconstruct the cortical part of the bone, and in the middle of the blades we utilize autogenous bone chips. This is how we start the case, and as you can see, this is a truly difficult case. As you see that the papilla between the 21 and the 22 is very high, and we start the case with a small high of this papilla. These patients has suffered a trauma, and they try to replace the teeth in position in the hospital. But what they get is to left an apex there, and the patient comes with a fistula. So my first intervention was to raise a little flap without going through the mucal gingival line in order to don't have scares in my periosteum to the second surgery, because if I have made scares at this time in my periosteum, I will not have the same amount of flap advancement in the second surgery. So I open a little flap, I took the root out, and I put some PRF inside, and then we put some stitches, 7/0 stitches, and wait for the healing. At the time of the graft, we always take care of the position of the blade to do our incisions. As I said before, it is very important to split the tissues in the proper way. And as you can see, even for vertical augmentation that we are using buccal blade and palatal blade in Corey technique, we are just utilizing one vertical releasing incision. Here you can see the magnitude of the defect. It's a vertical defect. We don't have palatal wall, neither buccal wall, but we have good bony peaks. In these cases, our preference to collect the graft is the mandibular ramus. We always perform a double plane incision in the external obliqual line. This incision I learned in the orthodontic surgery, and we also use some instruments that came from the orthodontic surgery that I will show you in some photos in the next slides. This is one of the instruments. This is a ramus periosteum, and this is a Langenbeck with the same design of the tip. First we go for the longitudinal cut in the bone, and then for the two horizontal ones, and in the horizontal ones we should pay attention in order to have an expulsive design of the bone, to not have bad fractures and don't get with our bone block stuck with a bend design. So as you can see in the left side of the slide, this is the ramus periosteum, and in the right part of the slide you can see that I have a good field to take out my ramus graft, because I'm utilizing the Langenbeck with the same tip of this periosteum. So then to cut the bone, I always utilize piezo device, and then after we cut the bone we start to split and to shave it in order to have a proper design. And these are some photos. As you can see, we have buccal plate, we have palatal plate, and in the occlusal part we put also a buccal plate. Here, as you can see in the left part, this is an error, because this plate should be in touch with this bony peak. And you will see in the reopen that I got some resorption here in this side, because I'm not getting the right information from this bony peak. This is our sutures, this is our healing, always the same pattern, one vertical releasing incision, we don't need more to advance this flap. And this is 12 days healing site. As you can see, a thin periodontal biotype. As you can see, the screws through the transparency. Every time we use this technique, we use this flap I just put these photos here to enhance one more vertical reconstruction with the 3 blades, occlusal, palatal and buccal one. And as you can see in this picture, only with one suture we have more or less our flap closed. So after the time of the graft to heal, 4 months, we have this situation. And as you can see here, we can see the screws through the transparency. And at the time of the reopening, we use the same incision design to reopen the case and to take out the fixation material. If we not have to take out the fixation material, we will not open the flap the second time. And as you can see in this picture, I got some resorption here due to don't have contact of this bony plate with this bony peak. So pay attention at this in the next graft that we'll do in order to don't have the same complication that I have in this case. After this, I use my surgical guide to drill my implant, and I harvest a subepithelium connective tissue graft, and I put this graft suture above the little resorption that I have. We suture everything, and this is our healing pattern. After 2 weeks, we have this kind of situation after the implant placement. At that time, we have made an index, and I use my surgical guide that could be a screw provisional, a bonded provisional, or a surgical guide. I use this surgical guide to fabricate my screw provisional for the case, and in the reopening of the case, I go again for the palatal island flap. I have collected 3 gingival graft that I have deepitalized, and I will tunneling this deepitalized gingival graft in order to gain some volume in the buccal side and gain some high in the papillas. The provisional could not be the most pretty one, but as I said before, the beauty of the provisional is in it. So as you can see in this slide, we have gained some high in the papillas, and this is how we have the case to make our final impression. And we came from this situation to this, and now we are able to place the final restoration in our patient, zirconium monolithic ceramized in the aesthetic zone. And this is our final situation. We have lots of volume and we have an acceptable situation for where we are coming from. So there is beauty in simplicity, and this is my message to you. I hope you all enjoyed the lecture and start utilizing autogenous tissues more and more in your clinical practice.